virtual coffee morning? Brilliant, thank you, Mum. And today we're talking all about COPD. And so just to let you know, as you have just heard, there's a little automated voice there, just letting you know that the meeting is being recorded. And this means it will be uploaded to our YouTube and our website. So please do just turn off your video if you're uncomfortable with being recorded. That's not a problem. We do mute everyone as you come into the room, just to make sure that we can always hear the speakers. But then if you want to ask questions at the end, of course, you can just wave, put your hand up, or you can put your virtual hand up as well. You can also put comments, questions, feedback in the little chat facility. And we do really encourage you to ask questions this way. And also, please do ask them verbally at the end. Just a reminder though, please do not post any links or images. This is just to keep the safety of everyone in our Zoom. So if you are posting links or images, we may remove you from the meeting. And then just a reminder that we are active on social media. So you can follow us at ARCC Ltd. That's Twitter, Facebook, Instagram, and YouTube. So Mamun, are you just able to quickly share the agenda just so that people can see exactly what we've got going on? Brilliant. So yeah, you'll have a quick introduction, which will last about 30 seconds. And then you're going to be joined and you're going to have a beautiful presentation by Dr. Yogini Rasta. And then you're going to have a presentation by Sarah Cuff. We will introduce both of them properly as well, just before they speak. And then after that, as always, we give you the opportunity to ask your specific questions to the expert. So please save them up, write them down, or keep them in your head, but please feel free to ask those. And then, of course, we always do our little mini coffee hamper. So if we were all together, we'd be providing you with teas, coffees, and snacks. Obviously, we can't do that over Zoom. So we let 3 of you win a little coffee hamper that we then post to you. And then we'll go through our upcoming events and activities. And then you can get on with your day. So just really, really quickly, the reason we're talking about COPD today is just that it is a common condition that does affect middle-aged or older adults. And one of the really important reasons to talk about it is a lot of people may not realise that they have it. And we are super lucky in Croydon that we have a really fantastic service, the Croydon Respiratory Team. And their aim basically is to improve the outcomes of COPD patients here in Croydon. And they are like a really multidisciplinary team. They've got nurses, physiotherapists, doctors, healthcare assistants. So they work with you in a variety of ways to help basically patients with COPD. They are also able to provide home visits for those that are housebound. And they are mostly at Croydon University Hospital, but they also have services at other trust sites. So someone from the Croydon Health Services is Dr. Yogini Rasta, and she started work as a doctor in 2002 and has been a consultant chest physician at the Croydon University Hospital for nearly 7 years. Dr. Rasta has recently taken on the role of a secondary care lead for the South West London Respiratory Clinical Network. And she did a PhD at Imperial College London and the Royal Brompton Royal Hospital, looking at the role of physical activity in COPD. So as you can tell from that bio, we're pretty lucky that we have her speaking for us today. So Dr. Rasta, are you able to tell us a little bit about COPD and maybe a little bit about activity?
Thanks very much, Lizzie. Thanks for that introduction.
No,
and thank you, everybody, for coming to this virtual coffee morning to hear about COPD. So I think I did prepare some slides. I don't know if you want to share those, Lizzie. I'll try not to make it too boring. And it'll it's just really to help me remember what to say. As much as for everybody else. So next slide, please. So yeah, what is COPD? COPD stands for chronic obstructive pulmonary disease. And you might have heard the conditions emphysema and chronic bronchitis in the past, and that's what we used to refer to it as, but they've been brought together under one kind of umbrella term of COPD. So yeah, the clue's in the name. Chronic means it's lifelong, basically. Once you have it, you are unfortunately stuck with it. Chronic bronchitis talks about the inflammation and the narrowing of the airways, and emphysema is more about the spongy bit of the lungs, the alveoli. So if you remember anything from GCSE biology or whatever GCSEs used to be, O-level biology, you'll remember that the alveoli are the really tiny bits at the bottom of the lungs, which are air sacs, which are folded multiple times to give them a really big surface area for the air, once it's gone into the lungs, to travel across that really big surface area into the bloodstream. And the problem that you get in emphysema is that those really folded and tightly sort of stuck together structures get destroyed. So the surface area that you have for all that air to move in and out of the lungs is much, much more reduced. So you don't get as much movement of air. And also, because instead of having lots of small holes, lots of small air sacs, you get fewer but larger air sacs, the air gets stuck. So you get what's called gas trapping, and both of those things contribute to breathlessness. So yeah, the main symptoms of COPD are breathlessness, wheeze because of the narrowing of the airways, causing difficulty for the air to move in and out. So it causes noisy breathing, people cough, bringing up phlegm or mucus, and that can put them at more risk of getting chest infections frequently. Next slide, please. Just got a picture here to try and make it a bit clearer about what I'm talking about. So the chronic bronchitis bit is on the left-hand side. So instead of the airways being nice and open and having a wide lumen, a wide space to go for the air to pass through in and out, everything just becomes a bit tighter. So the muscles in the airway itself become bigger. So the airway doesn't open and close as easily. And then you get this buildup of mucus because of inflammation and all the immune cells from the body going there to fight off infection. So you get this buildup of mucus, further narrowing the airway, causing that wheeze, the cough, and the mucus. And then looking at the bottom bit of the lung, the sort of the end part, which was the alveoli, where the air exchange occurs, this is what happens. Instead of having these small air sacs, you just get destruction of that into one big air sac, so the air gets trapped. So hopefully that is something that makes sense. This is what it can look like. So this is what we look at when we see patients in clinic. On the left-hand side, this is a cross-sectional image of a patient's lungs. On the left-hand side, this is a normal set of lungs. So you've got this heart in the middle, the black bits of the lungs, there's a few white bits there, which are the blood vessels and the airways, but basically the lungs are this kind of nice grayish color, and you don't see much else there really. There are no holes in the lungs, but if you look over to the right hand side, you can see the lungs look much blacker, and you can probably appreciate there are some holes there as well if you compare to the other side, and that's the emphysema that I was describing earlier. And the lungs are blacker because there's more air, and air is black on the CT scan, so the air has become stuck. So that's the gas trapping that I was talking about. Next slide, please. This is a really bad sort of extreme example. So there's lots of holes on the left-hand side, but you can see on the right that it really looks completely different. And you can have such bad destruction of the lungs that you almost have no functioning lung at all. So the top of this person's left lung is basically not functioning. And what's happening is that the air is stuck in there. You can see all those black sort of compartments, and it's almost squashing any bits of good lung that are left and kind of compromising those bits of good lung, making the breathlessness worse. And this is particularly common, well, not common, but this is particularly associated with people who smoke Cannabis heavily. So the combination of tobacco and cannabis has got this kind of magnified effect of lung destruction. So we do see quite bad changes in relatively young patients who've had a heavy cannabis smoking history. So I just thought something that was quite interesting. Next slide, please. So yeah, COPD is predominantly caused by smoking, tobacco and tobacco with cannabis, as I mentioned earlier. And I've sort of said here that it has a worse effect with respect to lung destruction. In the developing world, it's also associated with smoke exposure from open fires. So, you know, people doing it in little enclosed spaces, cooking over wood or other things, biomass fuel, and they don't have good ventilation, so they're inhaling a lot of that smoke. Passive smoking can also cause respiratory symptoms and can increase your risk of developing COPD, particularly if it's happening at a young age and over a long period of time. And there's a condition called alpha-1 antitrypsin deficiency. So people who have this enzyme deficiency are at more risk of developing COPD, particularly if they smoke. So they're the main causes, really. But yeah, by far and away, the largest cause is smoking across the whole world. Next slide, please. So how do we diagnose COPD? Mainly it's due to symptoms. People present to their GPs with chest infections every year, or they feel out of breath, or they're coughing, bringing up phlegm, and they don't really know why. They might have a smoking history. Most likely they will, and a significant one. But, you know, we do see those patients who've smoked and smoked all their lives and are completely fine and don't have any problems. So there are some lucky individuals that seem to be protected, but the vast majority of people are probably not as lucky. And we talk about pack years, we count smoking history in pack years. So 1 pack year of smoking is equivalent to smoking a packet of cigarettes a day, so 20 a day for 1 year. So that's how we sort of gauge the amount of smoking that somebody's undertaken in their life. So usually 20 pack years usually is enough to cause some lung damage, but it can happen with less if your lungs are particularly susceptible, or like I already mentioned, if you smoke more but you are unaffected. It's a little bit of luck and genetics in there. The other way that we have to do things is, sorry, just go back to the previous slide. Sorry, so to confirm whether you have COPD, we have to show that there's a problem with the airflow. There has to be reduced airflow out of the lungs. So we ask people to do a breathing test. So some of you might have come across this. This is called spirometry. It's supposed to be undertaken in general practice. There has been a problem with this during the pandemic, because when you're asking people to blow out really hard and blow, 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 keep going, that can make them cough. And there's a lot of concern about people coughing without the health professionals wearing the right sort of PPE and spreading COVID. So in the last 18 months or so, there hasn't been much spirometry going on in general practice, and that has a knock-on effect on us underdiagnosing people who've potentially got COPD, and then delaying them getting the right treatment and other interventions. Next slide, please. So COPD obviously affects the lungs, but it doesn't just affect the lungs. We know through a lot of research that it causes problems with people's muscle function. So they get a lot of wasting of their quadriceps muscles, the big muscles in the tops of your legs. And that, as you can imagine, makes them feel weaker. So when they're walking around, they feel that they don't have as much power in their legs or strength. And that can make them feel more breathless. So it kind of goes into this vicious circle of breathlessness, which is being contributed by this loss of strength. Because they lose muscle bulk, they lose weight. So we do have some patients who've got quite severe COPD who are literally stick thin, because all of their energy is being used up in just the the work of breathing. They are at higher risk of cardiovascular disease, so getting things like angina, having heart attacks, other things like strokes. So it's something that we need to bear in mind and think about that when we're treating not just their lungs, but think about the patient as a whole. There is an association with thinning of the bones, osteoporosis, and that's due to lots of reasons. Some of that is due to less activity, so not as much weight bearing on the bones, so the bones are not as resilient, and also nutrition, other things which feed into that. And it causes depression. It can be very isolating if you are so breathless you can't leave your house. You're having symptoms all the time. Maybe you're going in and out of hospital. So it's a really important aspect of the condition, and how it, can make people's outlook even worse if their mood is very low. Next slide, please. So I've got a special interest from my PhD in physical activity in COPD, and there's a lot of good evidence about this and how this can help people with COPD. So we know that people who've got reduced physical activity, even at the point of when they're getting diagnosed and they're still quite early in the disease, that seems to have a very good relationship with their outcome, so how they're going to do, whether that's lots of admissions or whether that's looking at their mortality. So we recognise that this is one of the most important things that we need to do in COPD, is to make sure people can stay as active as possible. That helps to keep people out of hospital. It also improves their quality of life and their well-being. It helps them to manage their symptoms, breathlessness and other things, and some of that muscle weakness helps to improve their deconditioning, and it also helps reduce the risk of them getting readmitted. And I think Sarah's going to talk about some of this when she talks about pulmonary rehabilitation. I think that might be my last slide. Oh yes, so this is the last bit, talking about the missing millions. It's just something that I mentioned earlier about the lack of diagnosis. So we've only formally diagnosed just under 1 million people with COPD. I think these figures are about 2017 figures. But we know from kind of population data, epidemiological data, that there are a majority of the people who have COPD haven't been diagnosed yet. And a lot of that is around awareness, both patients and healthcare professionals, and having access to spirometry, so being tested to see if your lung function is or isn't normal, recognition of the symptoms that people may have been having for several years, that this is actually early COPD. So it's really important to try and get people diagnosed early so we can help them earlier, help them to stop smoking, which is the most important thing that you can do, getting medication started and recognizing that they're having infections and treating them early and stopping them from getting admitted to hospital, and also increasing their activity. Next slide. I think that might be the last one. Yeah, that's it. So I think I'm going to hand over to Sarah now. Are we doing the questions at the end?
Yeah, so yeah, thank you so much for helping us with that and giving us such a fantastic introduction, and really detailed as well about COPD. So I am going to introduce Sarah. She's going to give her presentation, and then we will basically open it up to the questions at the end. And there have been a few questions in the chat already, so we will obviously start with those after we've heard from Sarah. So for everyone on screen, Sarah Cuff is a specialist respiratory practitioner with over 5 years experience in respiratory care, and she has worked with the Croydon respiratory team for 2.5 years. And as a respiratory physiotherapist, Sarah specialises in the care of patients living with chronic lung conditions. So thank you very much for joining us, Sarah. I think you're going to talk to us a little bit about sort of the management side of things.
Yeah, thank you, Lizzie, and thank you, Dr. Asti, for that presentation as well. So, as Lizzie said, I'm a physio working with the Croydon Respiratory team, and I'm going to focus on today talking about more how we can manage patients' symptoms of COPD and what we can do to help with them living with COPD. So I'm just going to share my screen. Can everyone see that?
Yeah, we can see. Thank you, Sarah.
Okay, lovely. My colleague Jemima actually created this presentation. She did one very recently, so I'm using the same one because it's very good. So instead of going back to drawing board, repeating everything that she's done, I'm using it. So all credit to Jemima for this presentation. So I have got a few slides on what COPD is. So I'm just going to sort of whiz over them a little bit because obviously Dr. Asti has already gone through that a lot. But just to sort of highlight what COPD actually stands for. So chronic means it's a long-term condition. So it is a lot. It is something that it's not curable. It doesn't go away. So it's something that patients need to actually learn to live with and how to manage their symptoms. The O stands for obstruction. So that's where, as Dr. Asti said, where the airways are narrow and where the alveoli, the elasticity breaks down, and so the air gets trapped in their chest, and so that's what the obstructive part of COPD is. So it's the airways narrowing. Pulmonary meaning it's a lung condition that's affecting your lung, and obviously disease meaning that's a medical condition. I will whiz through this because Dr. Asti has already explained this, so I'm just going to go through this. As Dr. Asti say, the main cause is smoking, but other causes can be maybe if they're not smoking, if they've had lots of exposure to passive smoking, also if there's particular air pollution. So if they live in a very built up sort of urbanized area and there's lots of air pollution from planes, traffic, that sort of thing, as well as some jobs. We have actually come across some patients who are still working, or sort of a younger age group, because they've worked in factories or being exposed to things like asbestos or lots of dust, and that can affect and potentially cause or contribute to getting COPD. But as Dr. Asti says, you're more likely to develop COPD if you are over 35 and have been a smoker. And sometimes if there's a bit of a family history as well, that can also contribute. So the main symptoms of COPD is breathlessness. So generally they notice that you're starting to get more breathless on exertion. So maybe it's just doing your sort of day-to-day tasks, sort of the housework, that sort of thing, that people start to notice, oh, I'm not finding that quite as easy as before. And maybe they were able to go for regular walks, and then now they're noticing they have to stop more frequently. So it's getting a lot more breathless on exertion. Having a cough, that cough can be dry or that cough can be productive. So with the bronchitis part of COPD, you get inflamed airways, and that can cause increased production of phlegm. So some of our patients have quite a bit productive cough, so they're bringing up quite a lot of phlegm. They might find that also they get quite wheezy and tight in their chest as well because of the airways being narrowing and because they get breathless. That's also quite a common symptom that patients will notice. As Dr. Asti said, it's diagnosed as spirometry. You might have chest X-ray and blood tests as well. And some other questions that around diagnosis would be asking about their exercise tolerance and how far they can walk before they get breathless. Can they manage their day-to-day activities? So getting dressed in the morning, doing the housework, cooking, that sort of thing. Are they able to do that as easily as possible? How often they're getting chest infections is really important, and a really good insight as well into helping diagnose COPD. And at diagnosis, we might check your oxygen levels as well. So managing COPD. So obviously it's not a curable disease. Unfortunately, it's something that people have to learn to live with and manage their symptoms. And there are some conservative ways to do that. So the big one that we really want to encourage patients to do is to stop smoking if they already haven't. if patients continue to smoke, that will continue to contribute to scarring their lungs and causing further damage. And so that will continue to contribute to worsening of their symptoms and potentially getting more chest infections. So it's really important that every time we see a patient who is still smoking, that we encourage them to try and cut down or refer them to smoking cessation services. Even if we've seen them loads of time and they always said no, it's important actually as a healthcare professional, we still offer it every time that we see them, because the more we say it, the more it might actually, one time it might actually hit home with someone and actually encourage them to think, yes, I need to stop smoking. So that is the number one thing that we actually need to be doing with our patients, is offering them these stop smoking services and encourage them and support them through that. So that is something that we do with all our patients. And then as a physio, exercise is the second number thing that we want to encourage patients to do. So it's actually the guidelines actually say that doing some exercise is the number one thing to actually help manage patients' day-to-day symptoms and improve their breathlessness so that they can do their day-to-day tasks and continue to live the life that they want to. So we run what we call pulmonary rehab classes in Croydon. We have 3 sites in Croydon. So we try to make sure it's accessible to everyone to be able to attend pulmonary rehab classes. So our pulmonary rehab classes are normally a 6-week course that they attend twice a week. It's run by a physio, and they're tailored exercises to each of the individuals in the class to try and strengthen their muscles as well as strengthen their lungs. So the classes because of COVID, we're slightly smaller class groups at the moment, so we can try and maintain as much social distances as possible and clean the equipment between uses. But the idea is we do an hour of exercise. So we do strengthening exercises of the arms and the legs to get our muscles really strong, so that our patients feel that they can do those day-to-day tasks. And then we also do aerobic exercises. So aerobic exercises are the exercises that focus on training the heart and the lungs more. So that's doing step-ups, walking. We want these patients to actually get breathless when they're exercising, because we know that that is a normal response to exercise, is we get breathless. So if they're getting breathless, then we know we're actually strengthening our lung and heart muscles. And again, if we can do that a little bit more and get their lung and heart muscles a bit stronger, then they might not find that they get quite so breathless in their day-to-day activities. Pulmonary rehab also includes an educational talk at the end of each session as well, half-an-hour educational talk on various different topics for our patients, such as managing breathlessness, the importance of exercise, diet and nutrition, chest clearance. So we try to also educate them on other management techniques and things that they can do to support their breathlessness and continue to do after the course, so they have a little bit more knowledge about what their condition is and how that they can best manage it. And more importantly, once they finish the course, we sit down with them and do sort of a reassessment. So we see the progress that they've made, and we make an onward plan with them. We want them to continue the exercise. There's no point them coming to the course and then they don't do any exercise after it, because all that important gain that they would have made, unfortunately, it would be such an awful shame if they didn't keep it up. So we will support them in continuing the exercise at home. So we will give them a home exercise. Every patient will get a home exercise program to take home with them, so that they can do all the exercises that we do in the class can be done in the home environment. And then for patients who are maybe a little more high level, we can do referrals into local gyms. There are lots of different local exercise classes around, so we will encourage them to do that as well. But exercise needs to be fun for a patient to continue to do it. So if it's something that maybe they're like, some of our patients like to go swimming, so we encourage them to make sure they swim twice a week. So it's actually making sure that the classes are engaging and fun, so that is something that they will want to continue to do after they finish the course with us. So that's really, really important. And then other management that we do for our COPD patients is making sure that they have their annual vaccine, so their flu vaccine every year, and their pneumococcal vaccine, so the one against pneumonia. And that obviously will just help to reduce the risk of them getting severe flu or chest infections, because the more chest infections, recurrent chest infections that a patient has, the more chances it is it's going to actually cause further scarring and then damage to their lungs. So we want to keep our patients as stable and healthy as possible. So that's all of the conservative management for our COPD patients. Oh, sorry, I didn't know that this was here, sorry. So yeah, having a self-management plan. So like I said, having a home exercise plan, making sure that they are cutting down on smoking. And I think Dr. Rusty actually already touched on this, that a lot of patients with COPD also have other comorbidities. So it's important that those other comorbidities are also managed properly as well, so that their breathlessness can also be managed alongside that. What I was going to say was inhalers is the other management for COPD. So the conservative sort of management is your exercise, stopping smoking, having your flu vaccinations, and then sort of the medication that patients need to manage their day-to-day symptoms are inhalers. There are lots of different inhalers out there, and a healthcare professional who is trained in COPD and inhalers will choose the most appropriate one for that patient. Most importantly, it's important that patients can use their inhaler correctly. The different devices out there have different techniques to use them differently. So some you have to take a nice slow deep breath, some you need to take a fast sharp breath. So it's important that when we're assessing a patient for an inhaler, that they naturally know how to use it, and that they can use it with the correct technique, because if they can't use it correctly, they're not going to get all the drug into their lungs. And the different inhalers out there will depend on the severity on their condition, how many chest infections they've had, will depend on what sort of inhaler we think would suit the patient in terms of what medication they need. So predominantly what inhalers do is that they help to open up your airways. So they contain bronchodilators to help open up your airways. Some inhalers also contain steroid, which helps to dampen down any inflammation in their airways. So it's all about trying to keep their airways as open as possible so they don't feel so breathless. So there's two sort of types of inhalers. So there's a reliever inhaler and a preventer inhaler. So most patients will be on a reliever inhaler. So I'm sure you've heard of salbutamol. So that is the blue puffer inhaler that patients carry around with them, and they can use that as and when they require to help manage their breathlessness. And then their preventer inhalers is an inhaler that they should take every day to help keep those airways as open as possible. There's also medication called mucolytics. So the most common one that we sort of prescribe our patients are carbamazepine tablets. And this is to help patients who really struggle with productive cough, and they have a lot of phlegm sitting on their chest, but they're really struggling to clear their chest. We might give them a carbamazepine tablet to help loosen the phlegm so it's easier to cough up. And it's really important that we clear the patient's phlegm as easily as possible. We don't want their phlegm sitting on their chest because then they'll be more susceptible to getting a chest infection. So it's important that we make sure these patients are clearing their chest as much as possible. So when our patients do get a chest infection, it's important that they follow their self-management plan. So the self-management plan might include using their blue inhaler a bit more often. So using their reliever inhaler up to 2 puffs every 4 hours, so up to sort of 4 to 5 times a day. Make sure that they are using their preventer inhalers still and they've got the correct technique. We would advise that they're drinking plenty of water. Water can also help loosen your phlegm as well. So if they've got more phlegm than normal where they've got chest infection, that keeping hydrated is really important. The self-management plan might be to contact our team. We do give our number out to our patients, and we're a service they can tap into. So if they're unsure what to do to help manage their chest infection, they can give us a call and we can advise on these things. making sure that they also get plenty of rest, but also not to become too sedentary. We want them to remain active. So if they're currently enrolled in our pulmonary rehab program, we'd say stay away for the week, don't come to the class, but make sure that they're still walking around their home. We don't want them just to be lying in bed or sitting in the chair all day, because our muscles will just then get weak, and then patients find that they get more breathless. We can also clear our chest if they're really struggling with some breathing exercises. So there's something called a huff. So basically what we want to do is, coughing can be very tiring and very fatiguing for a patient if they're just coughing and they just can't get that phlegm up and cough it out. So we can teach them some breathing exercises. So we want them to breathe in through the nose, hold their breath for a couple of seconds, and then they want to breathe out through the mouth. And as they do so, they want to purse their lips as if they're blowing through a straw. That allows the air to get right into the bottom of their lungs and behind the phlegm. So then when they breathe out, the phlegm should move up. It's all about shifting that phlegm towards your main airway. And when that's sort of there, we can say, instead of coughing, try a huff. So it's a bit like misting a mirror up. So they want to take a nice deep breath in and sort of a big huff up. Like that. So it can help shift out the throat a little bit more easily, and then it normally makes them cough and they can cough out more easily. So there's sort of all the sort of things that we will help to manage a chest infection. If there is sort of no improvement in using their blue inhaler and drinking plenty of water and taking a bit more rest, they may need a rescue pack. So rescue pack is a pack of antibiotic steroids that patients have at home on standby, just in case they have a chest infection. So if we feel it's relevant, that we can tell them to start their rescue pack, or they can still go to their GP if they want. Making sure also for management of your COPD, eating well and keeping a healthy weight is actually really, really important. If you're overweight, then actually that extra weight can be, obviously, particularly if it's abdominal weight, can be sitting on your lungs, and it can make it harder to breathe. You get more breathless when you're walking around. So it's really important that actually we want to maintain a healthy weight, and if they are overweight, you give some advice and lose weight. Equally, we don't want patients to be underweight. So it's really important that actually they have a really maintained health weight. And normally with patients with quite severe COPD, we do see some of that sort of more malnourished patients, mainly because they're struggling to breathe so much. They use so much energy just to breathe. They're burning more calories than they're taking in. So those sort of patients, we want to make sure that actually we refer them to a dietitian to make sure that they're on a healthy eating plan and have nutritional supplements. That's really, really important. And if they're too underweight, then they're not going to be safe in exercising. So we want to make sure that they're at a healthy maintained weight. And it's just also important to look after their mental health. So I think Dr. Rusty did touch on it a little bit around sort of depression. So our patients, we find, get so very anxious and can be depressed because they are so breathless. And unfortunately, they can get themselves into a bit of a cycle, particularly if they're very anxious about breathing. So if they get breathless when they go for a walk, it can make them feel very anxious because they can't get control of their breath, and then they sort of stop doing that activity because it makes them breathless, but then they're going to get weaker, so then they get more breathless on other tasks, and it can get them into a bit of a horrible cycle where they avoid activity, get weaker, get more breathless, and that contributes to them becoming more anxious. And all in all, because they're doing less and less and they feel they can't go out and maybe see their friends or see their family or go out to the shops, they then unfortunately can get quite depressed as well. So it's looking after their mental health and making sure that actually we're there to support them as much as possible with that. So we will refer to services such as talking therapies for that, speak to their GP as well. So we try to encourage them to stay as active and sociable as much as possible to help manage that sort of mental health side of things, sort of try and break that anxiety, that cycle that patients can get trapped in. I've already sort of mentioned about keeping active, but there's obviously so many benefits to exercise. It's good for your bones, it's good for your muscles, it's good generally for your fitness and your quality of life. And it'll also benefit if they have got any other comorbidities such as diabetes or high blood pressure. It will also help to control that or stop a patient from developing those sort of conditions. And just very quickly, breathlessness, and particularly with anxiety, it's very difficult for patients. It's very difficult for patients to manage their breathlessness. Sorry, my manager's just looked in the room. I've lost my train of thought. Sorry. So all those things about exercise I've mentioned to help manage breathlessness, but very simple, just doing some breathing exercises to help control breath, to help patients' anxiety levels just slow down a little bit, can also help. And it's some of the exercises are very simple. So a really easy, very simple one to instruct patients to do is make sure they're obviously in a comfortable, relaxed position. But what they want to do is making sure that the breath in is a little bit shorter than the breath out. You want to make sure that their breath out is longer, because what COPD patients tend to do when you're breathless is do very short, shallow breaths. So you want to make sure that you teach them to breathe in through the nose. So as if you're going up the side of the rectangle, and as they breathe out, you want to go across the horizontal part of the rectangle. So and you want them to breathe all the way out before they then take that next breath in. So that's quite a nice visualized way of thinking about it, but also think about just counting can help. If you count in for 3, make sure they breathe out for 5. It's just very little simple things like that, but it can help for patients to feel in control of their breath, which is what it's all about. And I think that is it. So thank you very much for listening.
Thank you so much, Sarah. And please say hello to your manager in the background. No, that was amazing and so useful, because not only about COPD, but you just gave us so much information about, what you do with it. It was brilliant. It was brilliant. So we are going to open it up to question and answer, but there have been quite a few questions already in the chat. So I'll go through those, because obviously people have been really organised and prepared those already, or thought of them as we're speaking. So let me just go, is Premila there? Because you had a really, really important question. Do you want to ask it yourself? You can unmute, or I can speak it for you if you want. I'll just give you 5 seconds in case you want to unmute. Okay, so Premila basically asked, oh, here she is. Hi.
Hello. One second. I don't know whether I'm having the COPD or not, but I'm just thinking, I never smoked in my life. I don't know how this applies to me or not. I'm not sure, because I got connective tissue disorders. I have on and off breathing problems, but not like continuously or anything like that. I do get infection as well, so quickly, but I never smoked in my life. That's why I'm very puzzled. I'm not sure whether what I got is.
Shall I answer that one?
So, Dr. West, do you want to take that one?
Yeah.
Yeah. I mean, obviously, the forum that this is, I think we probably would avoid answering any direct personal clinical questions. But I think that if you are concerned about your breathing, you may have already tried, but it's worth discussing again with your GP. And if you're under a specialist for your condition, to discuss with that person as well. But if they feel it's necessary, some just basic tests like a chest x-ray, very simple things to do. And if they feel necessary for, respiratory opinion, we're available for that at the chest clinic here.
They do every 6 months, they do the oxygen level test at Media Hospital, Croydon University Hospital and everything.
I mean, that is beyond the scope of this talk, as this is related to COPD. It doesn't sound as if that's what is the case with you, but I would certainly consult with your GP and your specialist about your breathing difficulties, and they may feel that a chest clinic, so respiratory opinion is warranted, and refer you on to the chest clinic here.
Okay, right.
Okay, so if you are concerned, I'd consult with your GP in the first instance.
Yeah, I do go to chest
Is
clinic.
that okay?
Yes, thank you. Right.
Brilliant, thank you. Emma, are you able to come off mute? She may not be able to, because I know she's always in like 4 meetings at a time. But so if she's not, I'm happy to read her first question, which was basically, do people who have got COPD get referred to gyms automatically or for free, like those who have obesity?
There are GP referral schemes out there which COPD patients are eligible for. So we can do them if they're under our team, or the GP can do those referrals. I don't know what the case is like at the moment, since the gyms have reopened COVID, and what gyms are actually offering it, but I know that if a patient wanted to, GP can do those referral schemes, and they're normally about 12 weeks where they get those referrals. They last for, yeah.
Okay, brilliant, thank you. And Jay, are you able to unmute and ask your question?
Forgotten what my question was. I think what I wanted to say is thank you, Yogini. It was very informative in terms of understanding what COPD is all about. I am a smoker, but I won't say I'm a addicted smoker. I only take a smoke when I feel like, especially under pressure, when I'm working continuously for about 6-8 hours. What I wanted to know as a chair of ARCC is, how do we get diagnosed for COPD? Is that a service that is readily available? Because before today, I didn't know that there was for me to go to my GP and say, I want to be diagnosed. So you did mention that there are a lot of people that were not diagnosed, and for the last 2 years, especially under COVID, it was impossible, virtually impossible anyway. So is there a plan to start this process?
Very good question, Jay. We are, as we speak, trying to formulate a plan across London, actually, to restart this, this diagnostic service for COPD and asthma, spirometry. Historically, so before the pandemic, this was a service that was fairly readily available in primary care. So not all GP practices had somebody who was trained to carry out this test, but many did, and were doing this, fairly freely. The main concern now is around the whole infection prevention and control issue, because when you ask somebody to do a spirometry, you're asking them to do a forced breath out. And in some people, that will cause them to start coughing. And if you are coughing and spluttering everywhere, there's then this concern that you could be potentially spreading COVID if you are infected. And we don't routinely swab people before their spirometry tests. And that is something that has been discussed and is being discussed as well. Is that something that we can use to try and mitigate the risk? So that is why at the moment there is very little spirometry happening in general practice. So all of the kind of respiratory specialists across London are putting our heads together to come up with a really good plan about how we can support primary care, support GPs to restart this, because we know there are people out there that do need to have spirometry who've got symptoms. so we can either explain their symptoms and say, yes, you have got COPD or you have got asthma, or no, you haven't, your spirometry is normal. So we need to think about something else and not miss an alternative diagnosis. So it is very important. But right now, as of this moment, it would very much depend on your own practice, whether that was available for you or not.
Well, I'll certainly go and check it out with my GP anyway. But the reason for the secondary part of that question was very much as Asian Resource Center, we are absolutely committed to helping people to live longer and healthier. And at the end of the day, we can only ask for them to be made aware of what's out there as services, how to make them engage with those services if necessary. And if any one of their, through their diagnosis, require some preventive measures, as Sarah mentioned, then we can action it. And I would certainly like to, if I can't be diagnosed, I'd certainly like to join the classes that Sarah runs, because I would be much happier if I knew what I had as a problem that I can resolve. So that's the main thing that we are trying to address, is finding people that have got problem and are not aware of where to go. That's what we are looking for. Yeah,
I mean, information and education is just so important, because we want people to kind of, in general, just be in charge of their own bodies, be in charge of their health, and take control of that. And I think empowering people is so important.
Yeah. Thank you.
Thank you, Jay. So I'm just going to pass over to Emma, because she's patiently had her little virtual Zoom hand up for a while. So thank you for that, Emma. But yeah, I also wanted to just say, I love that you said that you want people to be self-empowered. That's what we're all about at the moment. So thank you so much for saying that. Go ahead, Emma.
Thanks very much, Lizzie. And sorry, I was busy coughing when you asked me to unmute earlier on, so that would be why I didn't. I had a couple of other questions, and one of them was around whether having asthma affected COPD and what kind of effect it has on it, because I mean, could there be a misdiagnosis between asthma and COPD, for example, in later life? And also, does vaping count in PAC years?
Shall I do that one?
Yeah.
So asthma can be quite difficult to diagnose. Sometimes it's very straightforward. Traditionally, it's what we call a clinical diagnosis. So we talk to the patient, what are the symptoms, get a really detailed history about what they're experiencing, ask them to do peak flow measurements. So we give them a peak flow meter, which they have to do a flow. I think I have one here to show you. Okay, it's been removed, fully infection control. So we ask them to check their peak flow at home and see what kind of numbers they're getting. Are they about where they should be for their age and whatnot? Spirometry and other tests help with the diagnosis of asthma. COPD's got similar, there's a lot of overlap with COPD, and we do have patients who are diagnosed with both COPD and asthma. But we can get people who are kind of labeled as asthma and they've got COPD and vice versa. So I think it is important to get the diagnosis right, because there are subtle differences in how we manage patients. The types of inhalers that you can have in COPD are slightly different compared to asthma. There are a lot of commonalities between the two, certainly, but yeah, trying to get the right diagnosis is important, so that you get the right treatment. So I hope that answers the question about COPD versus asthma.
Yeah.
Regarding vaping, I think the jury's still out about vaping. I found it interesting that the MHRA, so that's the organization in this country who approve medicines and medical devices for prescription and use as a medicine, they have begun the process of approving a certain number of e-cigarettes, vaping devices, for people to prescribe to help people to stop smoking. I am not sure what I think about that. I think vaping is still a very new kind of technology, if you like. There are certainly some things that are not in vaping fluid that are in cigarettes, like tar and some of the other substances that we know are harmful. But we don't have the same track record or evidence base yet for vaping. It may turn out that vaping is, you know, substantially safer than cigarette smoking, and that is the right thing to do to try and help people to stop smoking. But I am still not sure about that.
And is that the same for Shisha, which is commonly used within our communities? I think that's probably more applicable, and it's got a much longer history of practice.
So Shisha is known to be associated with COPD and lung damage, because the way that people inhale Shisha, it's a much deeper breath, and the concentration of the substances is much stronger just because of the way it's sort of prepared with the water and everything. So we do know that that is associated with lung disease. Yeah, we should be kind of asking about that when we see patients, you know, not to kind of stereotype people, but it can be a very relevant question for people from certain communities, or in general. You know, some people might do it recreationally just because they're out with their friends. So it's something that we ought to bear in mind when we're asking about smoking history. So we always ask about smoking in terms of packs of cigarettes, or if they smoke roll-ups, we ask about the amount of tobacco per week that they smoke. So we should always also include that in our questioning as well.
Great. Thank you. Thanks for answering those. If anyone else has a question, please do feel free to put up your physical hand or your little virtual hand. But I'm going to sneak in and ask a really quick question. I hope it's quick. So what does it mean when a person sort of gets like a cough every winter? So it's not necessarily associated with flu, it's not phlegmy, it's just when it starts to get cold, you start to cough, and then in summer it sort of goes away again.
Could be lots of reasons. Could be a sign of airways disease. Some people who are asthmatic, not saying that that's the reason for that, but do find that change of weather brings on a worsening in their symptoms. But equally, you know, some people are worse in the hay fever season. So it very much depends on what triggers different people. But if it's something that's kind of always happened and it's problematic, because we do know that people have more coughs and colds generally when the weather's worse, but if it seems to be something over and above that, then it's worth consulting your GP.
Okay, that's cool. Thank you. So I can't see any more questions at the moment. I'm not really expecting to, because you guys were really thorough, extremely detailed. So that was amazing. So the last thing I just had from Susie was to ask, are you able to share your slides with us at all, that we can then distribute to the people that were here today?
Yeah, sure, that's fine.
Yeah, okay, brilliant.
Yeah,
I'm sure
I would
Susie
also
will
say,
be
if anyone wants any further information, the British Lung Foundation is a fantastic website for patients as well as healthcare professionals on what COPD is and the management of COPD. There's lots of information and some great tools and videos on there. So yeah, please do have a look at that as well.
Brilliant, thank you. Alrighty, so basically, I understand, Dr. Raste, if you need to rock to your clinic, please do so. But I will just pass over to my colleague Naeem.
I will actually leave. So thanks very much for having me.
Thank you very much. Thank you. I'm sure everyone here appreciates it. Thank you so much. And Sarah, likewise, if you are in clinic,
Yeah,
please.
I've got some home visits to go on, so I will run away as well. So thank you so much, everyone. I hope it's been useful.
Oh,
Really useful. Thank you so much. All right, so what Naeem is going to do for us, and obviously if Sarah or Dr. Raste win, we'll let them know, but we're just going to do our little raffle for 3 people to see if they win our little coffee hamper as our sort of substitute for the fact that we can't give you coffee in real life. So if you can go ahead and spin that for me, Naeem. Okay, brilliant. So Charlotte, you're our winner, and I think that Charlotte, oh yeah, Charlotte Barron. So if you can just write that down for me, Naeem, that would be fantastic.
All right, stop. Thank you, Lily. So that's the second person now.
Yay!
Well done.
That's really good, because you're fantastic. You come to so many of our talks and things, so about time you won. Brilliant.
Brilliant.
And our last
person.
one.
oh, wonderful.
Oh, yay. So that's our lovely respiratory physiotherapist, Sarah. That's nice, seeing as she presented such a good talk, she wins as well. Thank you so much, Naeem.
Thank you.
Emma, you got your hand up?
Yeah, I have. Thanks, Lizzie, and thank you so much for the whole year of health coffee mornings that you've done. And as people know, that ARCC had changed the format for our coffee mornings into health coffee mornings given the pandemic situation. Apologies, I've got a bit of a chest infection going on, so my voice probably not coming through as well. I wanted to personally invite everyone to our AGM that's coming up on the 15th of November at the Grand Sapphire from 11 a.m. to 1 p.m. As always, we're expecting that we're going to have a really good turnout. Oh, looks like Naeem's already prepped. So sorry if I stole your thunder there, Naeem. But I just wanted to make sure that I gave a personal invite to everyone to come along and hear about all the incredible work that's been happening at ARCC, including these brilliant coffee mornings. And I think we reached out to thousands of people throughout the year and really shaped our delivery to accommodate for this global crisis that we've been going through as a human race. So again, please, if you can, it's in person, please come to the Grand Sapphire. It's a prestigious, brilliant venue, thanks to our chair for arranging this. So it'll be great to see you all there and be able to answer some of your questions or give you some information about our organisation. We'll have some light entertainment and food there as well. So that was it really, Lizzie. And just to say thank you to Lizzie for again for hosting all these coffee mornings. We are going back to our regular coffee morning format, which is around sort of celebratory themes, topical issues, and celebrating really big events like International Women's Day, International Older People's Day, Diwali, and that's coming up, Eid, etc., those kind of things. So, and we are trying to go back slowly to face-to-face coffee mornings. So the next one actually will be virtual, but after that, we're hoping we're going to go back to a person one and see the 70, 80, 100 people that we used to see in the room again. So thanks very much, Lizzie. I just wanted to say that.
No worries. Cool. So yeah, basically I just got to go through our events that are coming up. So if yeah, thank you, Mamun. So we have got an event next week on Tuesday the 9th of November. It's called The Road to Recovery. It's part of Bina's amazing mental health work that she's been doing with us. So please do join us. And the nice thing with this one is it is face-to-face. Hooray! So you can join us at the big local Broad Green Hub, which is on Keeley Road, which is basically behind the Central Shopping Centre. So really looking forward to that one. Thank you, Mum. And then I only found out about this one today myself. Anyone that knows me that I love Christmas. So I'm very excited about this. So we're doing our winter grotto. This will be on Saturday, the 11th of December, 11 a.m. to 3 p.m. And this is also at the big local Broad Green Hub. So you guys hopefully will become very familiar with that place if you're not already. And this is literally for no other thing other than for fun. So I can't wait for that one. So please do join us there. And then we have got a fantastic program called Winning Women that is being organised by the big local Broad Green. And we've got 3 different styles of support or exercise. So on Sundays, it's dance. On Mondays, it's Thai boxing. And on Thursday, it's multi-sports. So we have super variety there. And if you want to know more information, then you can just contact Kat, who works at the big local Broad Green. You can always email us if you need to have her contact. And then, as you can see, we're doing huge amounts of stuff. So we've got our introduction to digital skills, and this is in collaboration with CALAT. And it's going to start on Thursday, the 2nd of December. So you've got a month to sort of make sure you've got free time. And it is going to be at the hub. And for this, there is a specific enrollment day. So please do make sure you come to that. So the enrollment session's on Thursday, the 25th of November between 10 and 12 p.m. And that's at the hub. But that's only for the enrollment. To be clear, the sessions will be actually at the CALAT Clock Tower Centre, which is the library building. If you want to know more information about that, you can contact our lovely Naeem, who is our IT all over expert. So he will definitely be able to help you. Thanks, Maman. And then, so this is just proof of how busy Bina's been providing mental health services for Croydon. So another one of her fantastic ones is anger management. And we're going to be joined by Gurpreet Singh on Wednesday, the 1st of December between 11 and 12:30 p.m. That one's on Zoom, so you can just stay on your comfy couch and join us there. And that one has been sponsored by Neil Camp Safe Deposit, who you guys know are massive supporters of our work and mental health here at ARCC. And then luckily, our amazing CEO has already introduced this one. So all I have to do is just a reminder, don't forget to register for our AGM. You don't want to miss out on the fun, a little bit of free food, Grand Sapphire, can't go wrong basically. So thank you, Maman. And just a reminder, this will be uploaded to YouTube. So if you know of any family or friends who do suffer with COPD, or perhaps are suffering with some lung conditions, coughing, anything like that, and you're thinking perhaps it could be COPD, then do share this YouTube recording with them, which will probably be up by next week. And Dilshad, of course, we can wish everyone happy Diwali. Of course. I hope that everyone has a fantastic celebration with your family and friends, and stay safe though as well, of course. So that's it for today. Please stay safe, enjoy, happy Diwali, and we will see you very soon at all of our events. Thank you.
Thank you.
Thanks.